تمام كده يا دكتور، حضرتك كده الهوست دلوقتي.
تمام. عندك شير سكرين وكل حاجة؟
حضرتك حالا هتعملي شير سكرين هيظهر.
طيب لحظة واحدة.
والجزء الاولاني مش ريكوردد كده بس
هعيده يا فندم.
ماشي شكرا جزيلا لحضرتك. شكرا جزيلا.
لحظة واحدة.
واسفين على الانتربشن يا دكتوره
لا يا
معلش.
فندم، لا يا فندم، انا مقدرة، مفيش مشكلة خالص. كده هنبتدي يا نور، ومسجلي حضرتك. تمام. بسم
يا
الله
دكتور
الرحمن
كله
الرحيم.
تمام.
تمام، توكلنا على الله. بسم الله الرحمن الرحيم. This lecture is about introduction to chest imaging regarding the extrapulmonary lesions. Now we should be acquainted with the mediastinum imaging, the diaphragm imaging, and the chest wall imaging. First of all, starting by mediastinum imaging, we should, by the end of this lecture, be acquainted with the normal mediastinum lesions of normal structures of the mediastinum, then superadded focal lesions, the diffuse lesions affecting the mediastinum and lymph nodes. To start with, there is a quick anatomy review. This is an axial mediastinal window image of a CT with IV after IV contrast. To say this is a mediastinum, anatomically, we have to have the sternum anteriorly. If we don't see the sternum anteriorly, we are still at the root of the neck. Now, seeing the sternum, this is a mediastinum. Starting, we have the spine behind, and this is the trachea, and in between this trachea and the spine, we have the esophagus. From behind forward, we have the left subclavian, LS, the left common carotid, LCC, and the brachiocephalic artery, BC. Anteriorly, just behind the sternum, we have the veins, left innominate vein, and crossing behind the sternum, and the right innominate vein. At this level, we have starting of the aortic arch. We have the left innominate going to join the right innominate. They are also called the brachiocephalic veins. At this level, this is the arch of the aorta and the superior vena cava. It's very important to notice that at this level, we have no other vascular structure, no other structure, but the arch, the superior vena cava, the trachea, and the esophagus. Anything else will be a pathology. This is a very important anatomical point. Now, at this level now, we have the main pulmonary artery, the left pulmonary artery, ascending aorta anteriorly, descending aorta posteriorly, and superior vena cava and the superior pulmonary vein. Here we have the main pulmonary artery, left pulmonary, right pulmonary, again, and ascending aorta, descending aorta, superior vena cava, and we can see now the left superior pulmonary vein. We are here below the level of hilum, so we start to seeing the azygos vein, as you can see. It was not seen before, and it will continue to the upper abdomen. Now here we have the atrial level, the right atrium and the left atrium. Now, and this is the ascending aorta at this level is now called the aortic root, and this is a very important change of nomenclature when describing an aneurysm or a dissection, okay? And this is anterior, we have the right ventricular outflow tract. Most posterior, we have the left descending artery, a branch of the pulmonary artery, left pulmonary artery. This is now the coronary artery. It's very clearly seen, the left coronary, which is actually a branch of the left anterior descending artery. Here we have the aorta, the root of aorta descending, and the left inferior pulmonary vein can be seen here, joining the left atrium. At this level, we have the aortic valve, the AV stand for aortic valve, and we have the 4 chambers. At this level, again, we have the 4th chamber, and we can see the site of the tricuspid valve, the mitral valve, and the IVS interventricular septum. Here we are nearly flushing with the diaphragm, and we can see that the right atria is nearly finishing. Now it is joining the coronary sinus, the CS. Coronary sinus is the venous drainage, is the site of venous drainage of the heart, and the IVC, which is inferior vena cava, before it enters the abdomen, and the descending aorta, as you can see. This is another patient showing a very important normal anatomy. This is, again, the left innominate or brachiocephalic vein joining the right brachiocephalic. And here we have the azygos vein from posterior to anterior entering the superior vena cava. This takes place just above the hilum, okay? And here posterior, we have partial azygos vein. Another anatomical that an anatomical important thing that we should know, this triad in another patient. We have this two, this black structure is the upper lobe bronchus. Anterior to it, we have a tubular vascular structure, which is the left superior pulmonary vein, and posterior to it, we have the descending branch of the left pulmonary artery. This triad is very important. If we miss the left superior pulmonary vein in this site, it's a sign of partial anomalous venous drainage. Here we have a 7-year-old female patient. Now we have the sternum anteriorly, and there is a soft tissue structure behind the sternum in front of the vascular structures. This soft tissue structure density is very homogeneous, and in this 7-year-old female, this is a normal sinus. Here we have the sternum. What's behind the sternum is the anterior mediastinum. What's behind the trachea and the heart is the posterior mediastinum, and the vascular structure, the heart and the trachea, all constitute the middle mediastinum. So, and this is a normal sinus in 7 years old, so this is normal. Now the trachea. The trachea this is a scanogram. As you can see, it's a tubular lucency. It is very uniform in caliber. This is a MINIP image showing the very uniform caliber of this structure, the trachea, and its normal branching. Here we have axial images of the trachea. In inspiratory study, we have a cross-section which is oval or rounded, while in expiratory study, we have a flat posterior membrane. And this is a very important thing here is the mediastinal image. نور بعد إذنك ممكن نقفل الكاميرا بتاع الناس؟ نور. Anyway, we have
يا نور لا لو سمحتوا يا شباب، في حد اسمها لمياء، ممكن يا لمياء تقفل الكاميرا بتاعتك؟ اوكي اتفضلي يا دكتوره يسري.
شكرا يا فندم، ميرسي لحضرتك يا فندم. Now, very important here, look at the mediastinal image of the normal trachea. You hardly see a wall, even with calcification, which is related to aging. The anterolateral aspect of the trachea is cartilage that by age will start to calcify. Okay, so it is just a rim, very thin, hardly visible. This is very important because anything else is a pathology. So the trachea has a uniform caliber along its whole course, and these are its configuration in inspiration and expiration, and this is its appearance in the mediastinal window. Now, by age, the trachea may be indented slightly by the dilated, unfolded aorta, and it's slightly displaced to the right side, as you can see here. And this is its appearance, again, by the aortic indentation. In the PA film, you can see the trachea displaced right, and in the lateral film, the lateral view, you will see the trachea displaced posteriorly by the aorta. This is an aging process that happens to everybody in case of dilated, unfolded aorta. Now, lesions of the normal structures. What we have described the normal structure. Now let us start making lesions in them. Starting by the vascular structures here. Well, we have what can happen anywhere in the body to a vascular structure? Well, it can have a congenital changes. For example, it might be missing, it might be displaced, it might be in another place, it might be duplicated. These are congenital problems with vasculars. Other lesions that they are acquired lesions, they may be dilated, they may be narrowed, they may be obstructed. Okay, so these are, as any part in the body, this can also be seen in the vascular structure of the mediastinum. Now let us look here at the first image. We will see the left subclavian, the left common carotid, but on the other side also we will see two vessels. The posterior one, which is on the right side of the esophagus, you will follow it, you will find it extending behind the esophagus to join the posterior aspect of the aorta. What is this? This is an aberrant right subclavian, okay? Now, in this image, actually, we have all the branches of the aorta on the right side. When we see all the branches of the aorta on the right side, we have to look at the superior vena cava. When the superior vena cava is on the opposite side, this is a mirror image. This is so the aorta on the right, the superior vena cava on the left. So this is a mirror image, and this is usually a case of situs inversus. However, in this case, this one, we have the aorta on the right and the superior vena cava in its normal position. So this is only a right side aortic arch. In addition, as you can see, there is an aberrant vessel on the left side, which is an aberrant left subclavian. Now, in this case, we have a right side aortic arch, the superior vena cava in its normal position, descending aorta coming down on the left side. And in addition, we have this abnormal soft tissue lesion, paravertebral imposition, which is a case of sequestration. And you can see an aberrant branch arising from the aorta entering this lesion. Now here.
بي أنا على بالي
يا نور
أنت
يا نور نور
سلكي لا
ممكن تقفل المايك يا نور بتاع الاتنديز
دولة
نور يا نور
الزيارة اللي تجوش سلكي ليش أنت اللي فات لكم ስልክ ትቀባትና ዛሬ ተሞክሯል ሽማይታ ምንሽ ማስክ የት ገዝተሽ ኖ ለማንኛውም እንጂ
النور المفروض قفلت المايكس كده يا دكتورة يسرية.
ماشي يا فندم يعني شكرا لحضرتك. تمام. طيب. We were discussing the right side aorta, and we have seen right side aorta with contralateral superior vena cava in cases of situs inversus, mirror image, and we have seen right side aorta with ipsilateral superior vena cava, which only represent right side aorta. In this case, however, we have this right side aorta and another arch on the other side, which is smaller in size, so joining this aorta anteriorly. This is actually a double aortic arch. Double aortic arch can have the same caliber or smaller or bigger than the right aorta. Now, here we have a very important finding. We can see at this level, this is the aortic arch and superior vena cava. But we know now that this structure here, lateral to the aortic arch, is a pathology. This is not normal. When we find such a thing, there are many possibilities. What we do is to follow this vascular structure up and down to see where does it come from and where does it go. When we follow this structure downward, we found that it's actually a dilated pulmonary artery in case of pulmonary hypertension in a patient with this patient with mitral valve disease. So it is only a big pulmonary artery that has ascended to a higher level in cuts. Another case with the same finding. Now we're going to follow it up and down and see where does it come from and goes to. This is the normal here up. Now down, we can see that it has come from very high up in the superior mediastinum, and it's continuous down to the level of the hilum here. And MRI of the same patient show us that this structure is actually a persistent left superior vena cava. This is another case, CT image. Okay, showing a bilateral superior vena cava. This item is called persistent left superior vena cava. Now another appearance, similar appearance. Again, we will follow up and down to see what is this structure. When we followed this structure, we found that there are pulmonary veins entering it, pulmonary vessels entering it. So it's actually an anomalous left superior vena cava, left superior pulmonary vein, sorry. Following this downwards to the hilum, we see the missing of the left superior pulmonary vein in its normal site. As on the left side, this is what we have seen before. Should be normal. We don't see it here. Now, in another case, which more clear here, we see this is the upper lobe bronchus with the pulmonary artery branch behind and no pulmonary vein in front. Again, this is a sign equal anomalous venous drainage on the left. Now, what do we have here? We have a markedly dilated ascending aorta. A focal dilatation of an artery is an aneurysm. So this is an aortic artery aneurysm. What are the causes of aortic artery aneurysm? The commonest actually is atherosclerosis. This is a male patient, as you can see on the side, male patient 75 years old, so an atherosclerosis etiology is also considered. When we find an aneurysm, we should regard if there is ممكن نقفل الميكروفونات من فضلكم والكاميرات. What? دكتور هشام.
يا دكتورة يسرية أنا بشوف أنا بشوف
ما اعرفش ايه اللي بيحصل يا فندم.
بشوف المايكس كلها اهو بقفلها اهو. حاضر. يا
هي مشكلة يا فندم حكاية ان كل ما حد بيخش بيروح فتح الميكروفون والكاميرا دي.
لا ما هو يا
يعني
نور
يعني
نور.
ممكن ما يعني نبقى احنا بس اللي موجودين، ما فيش حد داخل معانا.
انا عارف هو فيه اهو حد اهوت.
ايه يا دكتور، هو ايه المشكلة معلش؟
جالاكسي ده فاتح المايك بتاعه، جالاكسي ام مش عارف
طيب هي
واحد.
دلوقتي دكتور يسرية هي الهوست، فهي اللي تقدر تخليه يقفل المايك.
ما هو انا بنتي عايزه ادي محاضره، انا مش كل 5 دقائق هقفل مايكات وهقفل.
لا يقفل ازاي؟ تقفل ازاي يا نور؟ طيب
خلاص تمام. اوكي يا نور. Okay, let's go on. Bismillah ar-Rahman ar-Rahim. Now we have a dilatation of the aorta in a 75-year-old male patient. The dilatation, focal dilatation of an artery, as I said, is an aneurysm. Okay, and being 75, it's most likely etiology is atherosclerosis. When we find an aneurysm in any artery, we should describe its extent. We should describe if there is thrombosis, if there is dissection, and its caliber, maximum caliber. Arteries involved in the aneurysm, and these are all points should be covered. Now here, in another case, again, we have focal dilatation of the anterior aspect of the arch and of the ascending aorta, okay? But this time it's a 12-year-old male patient. So the etiology is most likely something else rather than the atherosclerosis, of course. So in this case, it was a case of Marfan syndrome. Mind you, here, there is an artifact which is commonly seen with vascular structures that simulate dissection, okay, on the periphery of the aorta. But if you follow it, you will see that it's continuous outside the vascular structure. This is the clue to know that it is actually an artifact. Here we have another dilated vessel. This is the main pulmonary artery. Its focal dilatation of the main pulmonary artery is markedly dilated. This is an aneurysm of the main pulmonary artery. Here we have another case with dilatation, focal dilatation of the descending branches of both pulmonary arteries on both sides. And we can see here, as you find, there is dilatation of the artery, focal dilatation, so it's an aneurysm. And partially, it seems like the wall is thickened. When you see what looks like wall thickening in an artery, in case of CT with contrast, this is a chronic thrombus. Actually, you should see no wall in CT with contrast. You don't see a wall for the artery. You start seeing a wall, what simulates a wall, this is chronic thrombosis. So there is bilateral aneurysm of the descending branches, as you can see in the mediastinal images above and in the MIP images below. And of course, this is when bilateral aneurysms are found in pulmonary arteries, you consider case of Behçet. Now we have a descending aortic aneurysm, as you can see. Now what simulate wall thickening on the first image, this is thrombosis. It's a large thrombus. And now we have another finding. We have what looks like leakage here, okay, with minimal effusion. In this case, we have dissection, okay, and thrombosis. Which one is the main and which is the false lumen? Actually, it is considered the false lumen is most likely, the bigger lumen is most likely the false lumen, and the lumen with thrombosis is most likely the false lumen. So this outside, the lateral lumen is most likely the false lumen. However, in this, the second image, you will see a large lumen constricting the smaller one. The large lumen constricting a smaller one is definitely the false lumen. In this image, if you're, for the first while, you may say there is nothing, what's wrong here? I can't see anything. But if you look at the caliber of the main pulmonary and the ascending aorta, you will find that the main pulmonary is larger. Its caliber is larger than ascending aorta. The ascending aorta actually should be the largest artery in the body because it's an artery supplying all other arteries. The main pulmonary should be smaller than the ascending aorta. The caliber of main pulmonary artery is less than 29 millimeter. However, if you see the main pulmonary larger than the ascending aorta, it's a CT sign that suggests pulmonary hypertension, actually with a sensitivity and specificity up to 100%. We should never see a pulmonary artery larger than the aorta. Now, in this case, we have pulmonary artery and its central branches, all of them are enlarged. Is this an aneurysm? No, this is not an aneurysm. This is not focal dilatation. It's a dilatation of the main artery and all its central branches. This is what we call the sign of pulmonary hypertension. Okay, this is a pulmonary hypertension. And here we have also what looks like in the first image, what looks like thickening of the wall. Thickening of the wall, as I said, represent chronic thrombosis. These very large central arteries are seen in cases of bilharzia cor pulmonale and in case of atrial septal defect. But in case of bilharzia cor pulmonale, the heart is not enlarged, not markedly enlarged, while in atrial septal defect, the heart is usually markedly enlarged. So if you look here at the heart, it is only the right side of the heart enlarged. There is no significant cardiomegaly. Another thing in the lung window, you will see here the large central arteries and the abrupt change in caliber. You see the parenchymal artery as very tiny compared to their mother central arteries. Now, this is a case of bilharzia cor pulmonale, and this has the periportal prominence you can see in the upper abdominal images. This is another case of bilharzia cor pulmonale. It's a classic appearance. It's a spotting, actually. And you can see here the central arteries that are very large and the relative peripheral oligemia due to the small arteries of the parenchyma. And this is bilharzia, again, case of bilharzia cor pulmonale. It's not common nowadays to see such thing, but we still do see it. Now here we have the main pulmonary artery, and the right pulmonary artery show a large central filling defect with a saddle extension to the left one. A central filling defect is an acute thrombus. So now we have seen chronic thrombosis, how they look like, and this is acute thrombosis. This is massive thrombosis actually in a female with antiphospholipid syndrome. Now what's wrong here? Now we can see in the first image, the descending aorta, but on the right side, we have a vessel that is nearly actually larger than the descending aorta. This is the anatomical site of the azygous vein. The azygous vein is very large, okay? What causes enlargement such of an azygous vein or prominence of azygous vein? We have to consider looking at the superior vena cava and the inferior vena cava. Here's the superior vena cava is normal. Those streaks is due to the gush of contrast during injection, but it's normal. It's nothing thrombosed or anything. So we will go on. The azygos is seen here, and the next image it is seen also, and then it crosses to the other side, joining the hemiazygos. Below the diaphragm, as though the upper liver, we don't see the IVC. There is no hepatic IVC here. There is an aberrant vessel inside the liver, and now the IVC of the infrahepatic lesion, as you see in the next image, is on the right side, on the left side of the aorta, not the right. Also, what is this? This is an azygous continuation of the hepatic IVC. There is, and the infrahepatic IVC, is on the left side. Now, what do we have here? We have, this is the esophagus. This is the region of the esophagus, the descending aorta, azygos, and this structure is the esophagus. What's wrong here? There is circumferential smooth prominence of the wall with compromise of the lumen, okay? And then there are nodular and serpentine vascular structure seen surrounding the esophagus. The wall thickening, circumferential and smooth with compromise of the lumen, is esophageal varices, while the nodular and serpentine structures represent paraesophageal varices. In this case, we have esophageal varices again, and in this case, we have paraesophageal varices, okay? And in this case, we have massive paraesophageal varices at different phases, arterial and late images. And it's very large lesion. Actually, this patient presented with, he was diagnosed as possibility of a posterior mediastinal mass. Now, what do we have here? We have this plain X-ray with a double density behind the heart, okay? And the lateral image shows this lesion behind the heart, abutting the diaphragm and showing a fluid level. This is a classic appearance of a hiatus hernia in plain study. Another case, plain X-ray, we can see the double density and we can recognize a fluid level. In a more penetrated view, we can see the fluid level. And again, this hiatus hernia with a lesion behind the heart, abutting the diaphragm and showing a fluid level. This is a CT scanogram, and we can see here this retrocardiac lesion that extends into the upper abdomen, and the axial and coronal images show a large hiatus hernia, as you can see here, and axial and coronal images. The hiatus hernia. This is another case of hiatus hernia, but smaller in size, showing the stomach sliding up into the lower mediastinum, lower posterior mediastinum. Now, what do we have here? The barium shows you clearly we have an achalasia of the cardia. How does it show itself in our studies? This is a plain X-ray on the left side, and you can see here delineation. There is a line and a ground glass opacity delineating the area below the clavicle. This is a stand-up. Of course, this is just X-ray erect film. So this is how you see the achalasia in the PA film. Now, regarding the CT, we can see another case of achalasia. We can recognize in the scanogram the retrocardiac dilated esophagus, which ascend upwards on the right side, and the axial imaging showing fluid levels in the upper cuts and fluid containing dilated esophagus in the lower cuts. Another case of achalasia. This is the trachea in the first section with a large lucency containing lesion, air containing lesion behind. This is the anatomical site of the esophagus because it lies between the trachea and the spine. So this is the esophagus containing air, and then in the next cut, it contains air and fluid. Air and fluid level in an esophagus denotes there is distal obstruction. This distal obstruction could be organic. Maybe we will downwards, we will see an obstructing lesion, whether extrinsic or intrinsic, a mass, whatever. And then if you don't see a lesion causing this obstruction, then you are dealing with a functional obstruction. Okay, let's go down. Now we have a fluid level at the second image, then fluid dilating the esophagus, then again, lower down, fluid dilating the esophagus. We don't see any lesions, we don't see any masses. And then the stomach is totally airless, which is a very important sign of achalasia. So this is a case of achalasia of the cardia. In this case, again, in the upper cut, we have air-containing lesion behind the trachea in front of the spine. This is the dilated esophagus. And then air fluid level denoting distal obstruction. And then the fluid increases. And then behind the heart, we have a soft tissue density that indents the left atrium. And this actually is a proven cancer esophagus, biopsy-proved cancer esophagus. Okay, and as you can see here, the dilatation of the esophagus, as they used a classic teaching of surgery, that the dilatation in case of cancer is not as marked as achilles. What do we see here in this scanogram? If you look up, okay, you see the trachea, and surrounding the trachea, there is another lucency, which goes further down here, okay, till the upper abdomen. This is a dilated esophagus. And you can see here, this is a dilated esophagus all through. All through, we have a dilatation of the esophagus, and down we have interstitial fibrosis and cysts. This is a 20-year-old female patient with scleroderma. Total dilatation of the esophagus all along. Now finished with the esophagus. What do we have here? We have the trachea. This is the trachea. Behind it, on the right side, on the left side, there is the esophagus, and there is a lucency behind the trachea and beside the esophagus. This, as the first images, you can see we don't have a sternum anterior. So this is the root of the neck. This is the inlet or the outlet of the thorax, okay? And then in the next image, this mediastinum started, and we still recognize the lucency. And now we can see communication with the trachea. So we have a right posterolateral lucency communicating to the trachea, posterolateral to the trachea, okay? And at the level of thoracic inlet. This, as we described it, is a congenital tracheal diverticulum. Another case, again, this lucency at the inlet of, or the outlet of the thorax, whatever you call. This is a tracheal diverticulum, congenital tracheal diverticulum. Why congenital? Because the diverticulum that is posterolateral to the right side of the trachea at the thoracic inlet is a congenital diverticulum. It might be small, it might be large, but this is how it looks like. Now here we have the carina at the second image. Just above the carina, or at the level of a carina, we have an abnormal bronchus. This is the tracheal bronchus. In another case, this is a minute image. You see a bronchus, abnormal bronchus, arriving from the trachea just above the carina. This is the classic site for tracheal bronchus, above the carina on the right side. And you can see it's supplying the apical part of the right upper lobe. Okay. Now, in this case, we have the trachea, then the carina, and then the main bronchus, as you can see it here. Up right main bronchus, there is an aberrant bronchus arriving, not from the trachea, but from the bronchus. You can call this aberrant bronchus, you can call it displaced bronchus, or you can call it actually a tracheal bronchus also. It's an aberrant bronchus. Here we have another uncommon type of aberrant bronchus. This is the bronchial tree, okay? And here you have a bronchus arriving from the medial aspect of the bronchus intermedius here, okay? Though nothing should arise from the medial aspect of the bronchus intermedius, and nothing should arise from the medial aspect of the lower lobe bronchus. The lower lobe bronchus divides into segments finally, but arising from the medial aspect, this is the classical appearance of the cardiac bronchus or the accessory cardiac bronchus. The problem with this bronchus, it might cause nothing at all, but sometimes it may end in soft tissue, like in this case. This is an MR of the same patient, and this patient came with unexplained recurrent hemoptysis. And this actually was the cause of hemoptysis because it got infected, and it's a cause recurrent hemoptysis to this patient. Now, again, with the trachea, we have an abnormal shape of the trachea. The trachea normally should have the coronal and sagittal dimensions nearly equal. In this case of emphysema, we have decrease in the coronal diameter and relative increase with respect to the sagittal diameter. This is what we call the Sabry trachea, and we see it in case of COPD. Another abnormal appearance of the trachea is the lunate-shaped trachea, which again we have relative increase in the coronal with respect to the sagittal. We have what we call the tracheal index. Normally, coronal versus over the sagittal is nearly 1. Sabry, it's less, about half, and in case of lunates, it's more than 1. Again, the trachea, what we see here is a dilated trachea, markedly dilated trachea. It's bigger than the vertebra, okay? This dilated trachea affects the course of the trachea all through, okay? And even affect the main bronchi. This is a syndrome. It's a congenital tracheobronchomegaly called Monier-Kohn syndrome. It is not common, but it is a congenital cause of the dilated trachea, and it is usually associated with bronchiectasis. Next, what is we see more common is the acquired dilatation of the, this is a normal on the left side. في صور طالعه لي، اعمل ايه يا نور؟ يا نور
يا شباب في حد داخل باسم
دكتور
انصاف.
حضرتك اللي تقدري تقفلي
حبيبتي هو
المايك
ما بيدينيش، ما فيش مايك، هو صورة
لو
مش عارفة.
سمحت لو سمحت
طيب ممكن معلش اللي فاتح الفيديو يقفله؟
ممكن نقفل الفيديو بعد اذنك. في حد باسم انصاف لو سمحت يا شباب، ممكن الكل يقفل الفيديو والمايكس بتاعته بعد اذنكم.
هو كده ظاهر عندي كله مقفول يا دكتور.
لا
لا،
في انصاف،
في
واحد
فيديو شغال اهو. يا دكتور
دكتور انصاف، دكتور
انصاف،
اقفل الكاميرا حبيبي.
بعد اذنك اقفل الكاميرا بس.
Let's go on. Anyway, as we said, the congenital cause of dilatation of the trachea is not common, but the acquired cause is rather common. Any case with diffuse affection of the lung with fibrosis and so on, there will be relative dilatation of the trachea, as you can see here. Okay, this is a case of interstitial fibrosis. There is a relative tracheal dilatation. Now what we see here, we can see a wall for the trachea. And this is not normal. I said the normal trachea we should see no wall. It is imperceptible. This presence of wall suggests wall thickening. There is diffuse thickening of the wall of the tracheal wall. In this MINIP image, we have focal circumferential thickening of the wall, causing constriction, causing narrowing of the trachea. Okay, and actually the commonest thing that causes such a thing is prolonged intubation. Another case of non-uniform caliber with narrowing and displacement of the trachea. In this case, another case here, we have a mass surrounding the trachea at the level of the lower neck, lying between the mass, the trachea and the thyroid, with irregular calcification seen. In this reconstructed image, we see there is this thickening of the wall and non-uniform caliber extend into the trachea, the main bronchi, and the branches even. In axial image, we see a tracheostomy tube, okay? And we see circumferential non-uniform thickening around the trachea. And again, going downwards, there is non-uniform thickening of the wall, there is narrowing of the lumen, and there is irregular calcification. This was a case of laryngotracheobronchoscleroma. Again, this is not a common finding, it's a granuloma, okay, but this is how it presents itself. We have here, what do we see? We see narrowing of the trachea, irregular narrowing, irregular caliber, and there is thickening, there is calcification, there is thickening of the wall, and there is nodularity, and there is affection of the trachea and the main bronchi. What is this? Again, it is not a common lesion, but this is a tracheopathia osteochondroplastica, where there is thickening and calcification, ossification actually of the cartilage. The aim of all this is to show you deviations from normal. We have seen normal very clearly, okay, and we see what can happen to this trachea from narrowing, thickening of the wall, calcification, whether common or uncommon. But we should all be able to see the lesion. Now what we see here, there is again calcification and thickening and irregularity of the wall, but it involves the posterior membrane. It involves the posterior membrane. The posterior membrane is not cartilaginous, okay? It is membranous. The structure, the lesion that affects this structure with calcification is actually amyloidosis. Now, again, the trachea, we see a fluid level. We see air within, we see low densities within. These are secretion, tracheal secretions, okay? It's commonly seen in patients in ICU. Another case, again, of tracheal secretion with hypodensity, with air lucency, filling defects inside the trachea with such appearance are secretion. And again, as I told you, it is shown, usually seen in patients in ICU. Here on another case, we have a polyp, sessile polyp of the trachea posteriorly, as you can see. This could be seen in some granulomas like sarcoid. This can be seen in can be seen in sarcoid, can be seen in cases, for example, some cases of rheumatoids, not common, and also as a benign tumor. Next, we have here this strange appearance in the PA study, but we're looking at the CT axial image. We can see there is tracheoesophageal fistula and a tracheostomy tube. This was a case of cancer larynx, and he was operated upon total laryngectomy, and we find this appearance post-operative. Now in this 2 CT axial image, we have bizarre shaped calcification related to the heart. In axial images, it's rather hard to suggest what it is, but reconstructed coronal and sagittal image show clearly that this is pericardial calcification in constrictive pericarditis. Another pericardial lesion is massive effusion, massive pericardial effusion in this case. Now this finishes the lesions of the original structures of the mediastinum. Let's go to focal lesion. We will super add a lesion. This lesion added can be either in the anterior mediastinum, in the middle mediastinum, or in the posterior mediastinum. And we have stated how anterior mediastinum is behind the sternum and in front of the vessels. Posterior mediastinum is behind the trachea and behind the heart. And what lies in between is the middle mediastinum. This classification of mediastinum division is actually a division to state differential diagnosis, to make it easy for us to state a differential diagnosis. Now this is a plain X-ray, and as you can see, there is widening soft tissue density of the superior mediastinum, which extend into the root of the neck, accompanied by the displacement and narrowing of the trachea. This is a classic appearance of retrosternal goiter, of a goiter extending into the retrosternal region. This is a CT, another patient with a large, as you can see in the neck, there is a large left thyroid lobe, large and heterogeneous, and the mediastinal image shows extension of the thyroid lobe into the superior mediastinum with displacement and narrowing of the trachea. Again, this is a retrosternal goiter. Now, the anterior mediastinal lesion, there are 4 common anterior mediastinal lesions, and they all start by a T. It makes them rather easier to remember. The thyroid, okay, the thymus lesions, the teratomas, and the T lymphoma. So there are 4 T, the thyroid, which is retrosternal goiter, thymic lesions in general, okay, whatever they are, and the T for teratoma and T for T lymphoma, okay? Now what we see here is the anterior mediastinal lesion because it lies between the sternum and the vessels, and this anterior mediastinal lesion is heterogeneous of tissue density, but heterogeneous and show lobulation. This was a case of lymphoma, and it came for follow-up in a male 17 years old. In this case, this is a child, as you can see, there is still non-united centers here in the bone, and we can see a large mediastinal lesion with fluid, with fat, and with calcification, denoting we are dealing with a teratoma. We go to another very important point. How, in a plain X-ray, can we state that this is a mediastinal lesion? What is the criteria? What are the criteria, sorry, of mediastinal, being a mediastinal lesion in plain film? Number 1, to find a lesion that abuts the mediastinum. And medially, it cannot be demarcated from it. It merges medially with the mediastinum. So we find a lesion that abuts the mediastinum, medially it merges with the mediastinum, and laterally it is sharply demarcated. If we find such a lesion, this is a mediastinal lesion. Then we have another question to answer. Can we differentiate if this is an anterior mediastinum or a posterior mediastinum lesion? Well, in case of anterior and middle mediastinal lesion, they both merges with the heart. They give us the impression that this heart has enlarged with abnormal configuration. While in posterior mediastinal lesion, the lesion is demarcated from the heart, okay? So we find a lesion merging with the heart, this is anterior or middle mediastinal lesion. If you find a lesion that can be demarcated from the heart, this is a posterior mediastinal lesion. So in this case, we can see here what looks like a cardiomegaly, but it extends superiorly. It is not related to the heart. There is a lesion abutting the mediastinum and merges medially with the mediastinum, and laterally it is sharply demarcated. Okay, this is a mediastinal mass. This mediastinal mass merges with the heart. We cannot differentiate. So this is an anterior mediastinal lesion. Okay, can we go further? Yes, we can. So this is a mediastinal lesion. This is an anterior mediastinal lesion. We said that we have four common mediastinal lesions. What are they? Well, is this a retrosternal goiter? No, it's not a retrosternal goiter because it's not superior mediastinum and it's not extending to the neck and it has nothing to do with the trachea. Okay, is this a teratoma? Well, we have nothing to say it's a teratoma because radiological wise, we don't see any calcification. Is this a lymphoma? We have a single lesion. We don't have a superior mediastinal mass and we don't have lymphadenopathy, generalized lymphadenopathy. We have only a single lesion. So we cannot say this is a lymphoma. So by exclusion, we can say this is a thymoma. دكتور هشام انا طالع لي شلفطه على الصوره ما اعرفش ده جه منين باين عند حضرتك ده
يا دكتوره يسريه
جه منين ده مش عارف ده طلع لي مره واحده ما اعرفش جه منين
في خطوط صفرة كده
مش عارفه دي جت منين طلعت وطلع كمان اقفل وافتح مش عارفه
ده
مش من عندي
يا تسنيم يا نور في حد بيقول ممكن نمسحها.
ايوه يا دكتور معلش طب ممكن يا دكتور يسرية تخليني انا الهوست طيب على ما امسح الكلام ده.
طيب خليكي هوست اتفضلي فندم.
هو حضرتك كده لسه هوست يا دكتور؟
طب اعمل ايه؟ يعني اعمل ايه عشان ما ابقاش هوست حبيبتي؟ اقفل الكاميرا ولا اعمل ايه؟
لا من يعني من الصورة الناحية اللي في الجنب اللي موجود فيها اسامي الناس اللي حاضرين.
اوكي
حضرتك هتضغطي على ميديكال سبيس LLC وهيبقى مكتوب كليم هوست. حضرتك هتضغطي عليه.
انا ميديكال سبيس انا بضغط عليها ما ادانيش اي حاجه. استني كده ما ادانيش اي يعني مش مديني حاجه غير ان انا ممكن اعمل ميوت.
دكتور حضرتك كده تقدري حالا تشير سكرين.
تمام. Okay, what we have now is This is the sternum. Behind the sternum, we have a soft tissue density that is very smooth, that is similar to the muscle density on this chest wall. And it's very smooth. It's not a mess. It's a thymus. It's very clearly a thymus. What's wrong here is that we have a 19-year-old teenager with myasthenia gravis. This same normally looking thymus in this age, okay, will be considered thymic hyperplasia. Another case, we have here a lesion abutting the mediastinum, merging medially with the mediastinum, have a lateral margin in the region of the right hilum. It lies. This means I'm dealing here with an anterior mediastinal lesion. It's also seen in the lateral study, and in the CT, as you can see, there is a soft tissue lesion anteriorly, which was a thymoma. In this case, we have a lesion on the left side abutting the mediastinum. It looks as if the heart has abnormal configuration. It merges medially with the mediastinum, well demarcated laterally. It looks as if the heart has wrong, so it's anterior mediastinal in location. Is this a thyroid? No. Is this a teratoma? There is nothing in it that suggests a teratoma, no calcification or heterogeneity or whatever. Is this a lymphoma? No, it's a single lesion and there is no other lymphadenopathy. So it's most likely a thymic origin tumor, and it was actually a thymoma. Now, what do we have here? We have opaque left hemithorax and homogeneous opacification of the upper and mid zone of the right hemithorax, and we have shift of the trachea and the heart. In axial images, we have this very large anterior mediastinal mass lesion of predominating fat density and streaks of soft tissue density, which exert a mass effect on the mediastinum, pushing it to the right side. This appearance is classic for a thymolipoma, okay? And this is the same patient in MRI. You have the signal intensity of fat all along in the axial, coronal, and sagittal images. Now we have a middle mediastinal lesion. This middle mediastinal lesion is infiltrating the structure. We can no more see the superior vena cava. We see collaterals all through, okay? We see distortion of the carina and the central airway, okay? And this means I'm dealing with an aggressive malignant lesion. This is the classic appearance of a central bronchogenic carcinoma, and this was a case of small cell lung cancer. Now in this case, we have at the site of the left hilum, we see a lesion overlying the hilum. This lesion abuts the mediastinum, has a well-demarcated lateral margin, so we are dealing with a mediastinal lesion. But it is demarcated from the heart and the vascular structure, so it is and seen here to be in the lateral film to be retrotracheal in location. We have a posterior lesion. In the axial CT image with contrast, it is a non-enhancing, very homogeneous, hypodense lesion suggesting a fluid density. In MRI of the same patient, we see the bright intensity of the lesion. This is a bronchogenic cyst. In this case, this was a young male patient coming with trivial back pain. A plain X-ray was done, as you can see, and the plain X-ray showed a lesion overlying or overlay sign of the right hilum. It's separated from the hilum. It abuts the mediastinum, merges with the mediastinum medially, but has a sharp demarcation laterally, and it does not merge with the heart shadow. So this is a mediastinal lesion, posterior in location. The lateral film showed a vague density on the on the spine. The CT actually was very misleading. It showed a wide pleural base lesion with no signs of aggressiveness whatsoever. And actually, it is not a mass. It looks like a pleural base lesion in the right gutter, right posterior gutter, paraspinal gutter. However, MRI of the same patient in the same day, okay, showed the marked aggressiveness of the lesion. The lesion actually infiltrates the chest wall. And in the sagittal and axial images, sagittal and coronal images, it is even infiltrating the spine. Again, we emphasize here that in any lesion that is posterior mediastinum or abutting the chest wall at any area, we must do an MRI. MRI is a must, okay? As you can see, the marked difference here, the lesion was benign looking, actually. It has nothing, there is just pleural based, but the aggressiveness of the lesion, okay, is clearly seen, and the extension of the lesion is clearly seen in the MRI images. Now, in this case, we have multiple bilateral paraspinal lesions, paravertebral lesions, as you can see here in this female patient, and upper abdomen show a hyperdense liver and multiple gallbladder calculi and evidence of splenectomy. And this is MRI of the same patient, show diffuse low intensity of the vertebrae. This was a case of extramedullary hematopoiesis in a patient with hemolytic anemia. Now, diffuse lesions. How would diffuse lesion of the mediastinum look like? Lesions as a whole in imaging is either black lesions or white lesions. Black lesions in ours, we deal with air, this is a black lesion, and fat, this is a black lesion. So we have here air, black lesion, in the form of mediastinal emphysema and surgical emphysema, which is also called subcutaneous emphysema, okay, in this patient. This is diffuse affection here. In another case, this is a scanogram. As you can see, the pneumopericardium below the heart, between the heart and the diaphragm, and the streaks of pneumomediastinum in the superior mediastinum. Now, in this case, we have widening of the superior mediastinum, widening of the mediastinum, and in the axial images, in the lung window and mediastinal window, we have this widening showing fat density all through. This is exuberant fat in the mediastinum. This exuberant fat in the mediastinum is what we call mediastinal lipomatosis. It can be due to body build, or it can be due to corticosteroids. Corticosteroids, whether intrinsic in cases of Cushing or extrinsic, which is a very common finding because people treated with prolonged corticosteroid due to chest problem, due to carcinoma, due to whatever etiology are common to be seen. These were the black lesions. Now, white lesions. There is replacement of the fat in the mediastinum by a diffuse white lesion. As in this case, this was a case of left mastectomy, as you can see here, and there is focal local recurrence infiltrating the sternum and infiltrating the mediastinum. As you can see, there is erosion of the sternum and infiltration of the mediastinum. This is a case of metastasis and with infiltration of the chest. This was a white diffuse lesion. Another white diffuse lesion is seen here. This is a known case of Hodgkin lymphoma. There is, as you can see in the scanogram, there is widening of the mediastinum. And then what we see here is there is a diffuse lesion in the mediastinum. The fat of the mediastinum is totally replaced by soft tissue. But this soft tissue leaves everything alone. There is live and let live policy. The vessels are present, superior vena cava is present, nothing is injured. This is a classic attitude of lymphoma, live and live. It just spreads and leave everything alone, except sometimes it may compromise the superior vena cava. Now we have here two very interesting signs. The CT angiogram sign, the vessels inside the lesion, and the air bronchogram sign. Well, actually, the people know this patient has a mass in the mediastinum. They needed to know if this lesion extends into the adjacent lungs. Now, we see air bronchogram bilaterally. Bronchi are present in the lungs. Okay, so seeing air bronchogram means that the tissue, abnormal tissue around them is a lung tissue. So this means there is bilateral extension into the lungs. This is the importance of air bronchogram sign here. Now, finally, we have again total replacement of the fat of the mediastinum by soft tissue density. We have, as you can see, collaterals in the chest wall. There are two findings in the mediastinum. Three findings in addition to the already replacement of soft tissue density. Here, we don't see the superior vena cava, it is obstructed. And looking at the right main pulmonary artery, this is a very important classic sign for diagnosis. This smooth, diffuse, narrowing, okay, there is no infiltration, there is just diffuse narrowing, okay, and a very smooth one. This is a classic finding in fibrosing mediastinums. Now we finished with the diffuse lesion. Let's go to lymph nodes. Lymph nodes, a lot of lesions causes lymphadenopathy in the mediastinum. The classic one, the commonest one we see every day is the tuberculosis. In tuberculosis, what we see actually are calcific nodules in the mediastinum. When we see a calcified nodule in the mediastinum, which is usually a tiny one, we say this is calcified, most likely calcified tuberculous lymph node, okay? Now here we have a case of calcified tuberculous lymph nodes. They are tiny, they are irregular, and there is evidence of fibrosis and traction on the right side. In this case, okay, this is a case of sarcoidosis. Sarcoidosis lymphadenopathy has a very, very classic pattern, which is there is generalized lymphadenopathy, okay, but the most prominent is the right paratracheal and the affection of both hilar and the subcarinal affection. If it attains this classic pattern, this is diagnostic for sarcoidosis. Even a trained physician and experienced physician do not take a biopsy. If they see this pattern, they do not even take a biopsy. This is sarcoidosis. Lymphadenopathy with a classic large right paratracheal and affection, large bilateral hilar lymph nodes, and a subcarinal affection. Okay. In addition, if you see the lung window here, you will see the hilar here have a pattern that we call the parahilar opacity. The parahilar opacity, okay? This is another classic appearance of the sarcoidosis. Sometimes the sarcoid, this is a case of sarcoid, sometimes, which is not typical. The sarcoid lymph nodes may calcify. The pattern of calcification may be punctate, dense calcification, or vague amorphous calcification, or rarely it may have an eggshell calcification. This is a case of sarcoidosis. As you can see, the right paratracheal, the subcarinal, the bilateral hilar, and even the lower lobe, right lower lobe lymph nodes with calcification. In this case, there is extensive calcification of the lymph nodes. If you look at the lung window, you will see the classic eggshell calcification. You have heard this term a lot. This is the eggshell calcification, dense outer, relatively less dense inner calcification of the lymph nodes. In addition, you see there is fibrosis with calcification in the lung, and there is miliary pattern in the lung. There is miliary pattern in the lung, and this is a case of pneumoconiosis with progressive masses fibrosis. Again, a case with lymphadenopathy, but we have large nodules with dense calcification. There is total calcification of all the nodules. This takes place in amyloidosis, calcified mediastinal lymph nodes in case of amyloidosis. Mind you, amyloidosis is not a rare entity, okay? Because amyloidosis takes place, okay, as secondary amyloidosis takes place whenever there is a chronic illness. This chronic illness, whether liver cirrhosis, renal failure, malignancy, chronic lung lesion. So we expect it not to be a rare lesion. So don't ignore this diagnosis. Now, this is a case of cancer thyroid, okay, left thyroid lobe, where the cancer show irregularity and calcification, and the lymph nodes from this cancer extending, there is lymphadenopathy, metastatic lymphadenopathy, extending in the whole of the mediastinum, showing punctate calcification. So now this is calcified lymph nodes from deposit. This is a case of lymphoma that took chemotherapy, and as you can see here, there is a pericardial lymph node with eggshell calcification. There is a very important point here that pericardial lymph nodes in general are a very serious finding, because pericardial lymph nodes usually denotes malignancy, especially lymphoma. Then we have the diaphragm. What to know about the diaphragm? The aim is to know normal radiological anatomy, some normal variants, okay, and congenital anomalies, elevated copula, depressed copula, subdiaphragmatic lesions, and lesions simulating an elevated copula. And finally, miscellaneous lesions. Now, regarding the normal radiological anatomy, we do see this picture. We have a right copula and a left copula, and they are named copula because they are semicircular in appearance with the highest point lying in the middle, okay? The right is usually a little bit higher than the left. How bit higher? Less than an interspace, less than a vertebral body, okay? Less than a vertebral body height. The level of the right cupula, as you can see, is it's bisected by the 6th rib anteriorly on the right, and the left rib posteriorly is just above it. Again, we see clearly the smooth outline of this upper surface of the cupula, and we usually don't see the lower surface of the cupula in a plain study. Okay, this is the normal, the shape, the surface, and the position. Now let's go to some normal variants and congenital anomalies. This image is from David Sutton, 5th edition textbook. As you can see here, we have this scalloping. This is a variant. Muscle slips, this is a variant. The elevation of the anterior aspect and the medial aspect, which is usually right-sided, is a diaphragmatic hump. If it's a large hump, we call it a dromedary diaphragm. Now here, look at the lateral film. Look at the diaphragm. There is scalloping of the diaphragm. Look at the PA now on the right side. It's more clear. This is scalloping of the diaphragm. It's a variant. Here we have on the right side, there is an elevation of the medial aspect. On the lateral film, it is slight elevation anterior. This is the phragmatic hump. Here we have, again, elevation of in the PA film. It looks like we have a double cupula. In the lateral, it is shown that there is a large hump, which we call the dromedary diaphragm. The problem with dromedary diaphragm is it may simulate an elevated cupula. As you can see here, this looks like a markedly elevated right cupula. However, in the lateral film, it is only anteriorly. So before diagnosing an elevated cupula, we should make a lateral film. Now, what is this? This is an erect study, just PA, actually part of the film. There is air fluid levels, so this is erect. There is marked elevation of the left cupula with marked contralateral mediastinal shift. This is eventration of the diaphragm. Classic teaching, eventration is a congenital problem with the diaphragm, and this appearance that I've just described is pathognomonic of eventration. Left cupula, marked elevation of left cupula with marked contralateral shift in an erect person, in a chest PA, okay? This is spotting. This is the classic teaching. Nowadays, you may have many other parasites coming in. They may say eventration may be congenital, may be acquired. It can be due to paralysis, can be due to trauma. This is how you can be misled. You will not diagnose anything. Now let us consider this appearance with elevated left cupula, with contralateral shift in an erect person equal a congenital elevation, which is eventration. Now, elevated cupula. Here we have an elevated left cupula. Why is this an elevated left cupula? Why this is not, for example, an abscess? Okay. Why do we consider this a cupula and this is a subphrenic, not a supra or a lesion above the diaphragm? Now let us see. We have this here above the lucency on the left side. We have a whiteness or an arch extending from most medial to most lateral. Okay, and in the lateral study, it extends from most anterior to most posterior. This is the anatomy of the diaphragm. Okay, so this air fluid level is below the diaphragm. If this lesion was in the lung, it would have been either anteriorly in the lateral, lying in the lingula, or posteriorly in the lateral, related to the lower lobe, but extending from most anterior to most posterior in the lateral film, from most medial to most lateral in the frontal film. This is only fit with the diaphragm anatomy, and thus this air fluid level is subphrenic. Now we have marked elevation of left cupula. This is an erect study. There is marked contralateral shift. So again, this is eventration of the diaphragm. In this case, look at the frontal film, PA. We have elevation of left cupula. And in the lateral, we have elevation only of the posterior aspect of the left cupula. Elevation of the posterior aspect of the left cupula is diagnostic of a Bugdalic hernia. Okay? The CT of this same patient, this is how Bugdalic hernia look like. A Bugdalic hernia is a congenital hernia. It's a congenital defect, pleuroperitoneal defect, posterior pleuroperitoneal defect of the diaphragm. It's congenital, yes, but actually it does not present itself in childhood. It's an incidental finding in elderly. This is the usual presentation. How does it show itself in CT? This is a posterior lesion. As you can see, it abuts the wall with fat, and sometimes there is viscera, as in this case. So this is how buctalic we look in PA, in lateral, and in CT. This is another case, scanogram. You see the mediastinum is central. There is no shift of the mediastinum. There is elevation of the left cupula. And when you look to the axial image, you will find there is a lesion. There is viscera posteriorly, okay? This is the spleen, and this is the fat within. And this posterior abutting the chest wall here, this is again a buctalic hernia. No mediastinal shift whatsoever. In this case, we have a child with car accident. There is marked, this is a scanogram, so he's supine. There is a marked elevation of the left cupula, and there is marked contralateral mediastinal shift in the supine position. And as you can see in the axial image, we have the stomach inside and the mediastinum is shifted. This is a diaphragmatic tear and a diaphragmatic hernia. Now in this case, again, we have an elevated left cupula with a mass in the left hilum and a central mediastinum. The mediastinum is central. There is a mass and there is elevation of the cupula. This mass is a bronchogenic carcinoma. So this is this bronchogenic carcinoma has caused phrenic palsy and thus elevation of left cupula. Again, I stress the point, there is no mediastinal shift. Now, let's see here. This is a case post-operative. As you can see, there is median sternotomy evidence in the scanogram, marked elevation of the cupula. The mediastinum is central. There is no mediastinal shift. Okay, and there is hernia here. There is elevation. There is viscera inside the left hemithorax, but it does not abut the wall. Okay, it's only the viscera because it's higher in level, as you can see. This was no mediastinal shift. This was a case of paralysis of the diaphragm, again, due to injury of the phrenic nerve during the operation. It's diaphragmatic palsy. The diaphragm is elevated, showing the viscera below it. Here we have, in the scanogram, elevation of the diaphragm and ipsilateral mediastinal shift. So we have signs of volume loss, actually, in the left hemithorax. This patient had actually done a previous lobectomy, and thus there is volume loss, and we can see the elevation and ipsilateral mediastinal shift. Now look here at the right cupula. The right cupula is elevated. It is rather flat, and the highest point of the cupula is lateral and not central. This is the classic appearance of subpulmonary effusion. Elevation of the cupula with flatness and shift of the apex of the cupula, or shift of the highest point of the cupula laterally. In this case, we have two bilateral elevated cupula. Bilateral elevated cupula are maybe due to an abdominal cause, as in this case, it's caused by fluid, fetus, masses, etc. All these can cause bilateral elevation. In addition, the patient has also some atelectasis in the lung. Then we come to the depressed cupula. There should be a mass effect to cause a depressed cupula, a mass from above causing the depressed cupula, okay? So air under pressure, actually. In this case, we have bilateral flattening of the cupula and they are depressed downwards, okay? This means we have bilateral air under pressure in both lungs, and this takes place in COPD. In this case, we have unilateral depressed cupula on the right side with jet black lucency above. This is tension pneumothorax. Mind you, also by effusion, massive effusion will cause a depressed cupula, but you will not see the cupula except if you are doing a sonar, ultrasound, or an imaging procedure like CT or so, because otherwise you will miss the cupula. You can't see the cupula through the effusion. Here we see the depressed cupula. Then subdiaphragmatic lesions. As we said, in the normal, we see above the upper surface of the cupula because there is air above. We don't see the lower surface because there is no air below. When there is air below the cupula, we start to see it. This air can take the shape of air fluid level, as in this case. So this is a subphrenic abscess on the right side. It can take the shape of haustra of the colon in case of Chilaiditi syndrome, and it can be curvilinear, as in this case, which is a case of pneumoperitoneum. Pneumoperitoneum suggests we have a ruptured viscus, and it's usually a duodenal ulcer or that has got ruptured. Mind you, to diagnose pneumoperitoneum, it's much better to do a plain X-ray erect chest film, a chest PA film, or an AP film, whatever. An erect chest is better than doing a supine or an erect abdomen, because the density and the dose for chest X-ray is better to diagnose the air. Then we have lesions simulating elevated copula. We have here, is this an elevated copula with fluid below? No, this is the curvilinear uppermost part of the lesion is very thin. And if we do a lateral image, lateral chest X-ray, we will see the lesion posteriorly, and actually we can see multiple fluid levels. And this is a loculated hydropneumothorax. In this case, this scannogram will show an elevated, what looks like elevated left copula. However, if this is an elevated left copula, they can see the haustra of the colon far below. It should be just below the copula. It is not. Is there something below the copula pushing the haustra? No, there is nothing. Why am I so sure that there is nothing pushing the haustra? Because they are very uniform. There is nothing indenting them. In the axial image, you will see clearly that this was actually a loculated effusion, diaphragmatic loculated effusion, with underlying partial lung collapse. Miscellaneous lesions of the diaphragm. Here we have calcification in case of asbestos exposure. You see the left copula showing calcification. Here the right copula show calcification, and there is also calcification of the right paravertebral vertebral pleura. This again is a case of asbestos. Now in this case, we have haustra inside the left hemithorax. Okay, haustra in a hemithorax is hernia. Why isn't there mass effect? Actually, because there was total pneumonectomy, the lung is no more present inside here, and the operation resulted in diaphragmatic injury, tear, and hernia. Here we can see abnormal configuration of the left copula. In coronal image, we can see a defect of the diaphragm, so clearly seen, with fat extending into the lower and lateral aspect of the left hemithorax. This is a hernia, a tear and a hernia. And again, the same patient, axial images, we see the fat, and we see in the second axial image the defect of the diaphragms clearly seen. You have seen this a lot, the hiatus hernia behind the heart. In the sagittal image, you can see the large defect in the diaphragm with the stomach sliding upward. Okay. Now what do we have here anteriorly? You can see fat in front of the heart. A very strange appearance, and the sagittal image show a diaphragmatic defect. This is Morgagni here. Here we have another case of Morgagni's hernia with bowel extending upwards. Now chest wall imaging. What do we need to know? The normal variance.
دكتورة يسرية، تحب تاخدي ريست 5 دقايق ولا حاجة؟
لا صوتي علق بس. لا ميرسي.
اوكي ماشي، اتفضل.
ميرسي لحضرتك يا فندم. Okay, we need to know the normal variance and the congenital anomalies, fractures, miscellaneous lesions, some inflammatory lesions, and some tumors and pseudotumors. First of all, the normal variants and congenital anomalies. This image is very important. We need to know it by heart because not to be misled and diagnosing abnormalities that are not found. This soft tissues on both sides on the lower neck is the sternocleidomastoid shadow, sharply demarcated as you can see here and extending downwards on the apex of the lung or bilateral. This is the sternocleidomastoid. Above the clavicle, we have the companion shadow of the clavicle. Okay, so we have the sternocleidomastoid and companion shadow of the clavicle adjoining each other and adjoining the shadow of the first rib, giving false impression that we have a cavity. We might have false impression that we have bilateral apical cavities here. This sternocleidomastoid is not always seen, and if it's seen, it's not always seen bilateral, okay? And so the same for the companion shadow of the clavicle, okay? They may not be found, but if they're found, as you can see, they can lead to misdiagnosis, especially if they are unilateral. Okay, so this is sternocleidomastoid and companion shadow of clavicles, giving the false impression of a cavity. Here we have bilateral cervical ribs. How would I diagnose a cervical rib? What makes me sure that's a cervical rib? Especially the problem is when it is a large rib. A small rib is easily diagnosed. This is a cervical rib. But when it's large rib and it will be causing vascular and neurological problems, marked vascular and neurological problems, still they may be missed as a first rib. How would I know? A rib that does not, look at the right side, a rib that's so big, it does not reach the clavicle. A rib that does not reach the clavicle is not a thoracic rib. It's a cervical rib. However, look on the left side. The cervical rib reaches the clavicle, but at which part? At the medial part of the clavicle. The first rib either crosses the middle of the clavicle, the part of the clavicle crossing the lung at its middle, or its lateral aspect. It does not cross medially. So we have a rib reaching medial aspect of the clavicle. This again is a cervical rib. So this is bilateral cervical rib. Again, a cervical rib does not reach the clavicle, and if it reaches the clavicle, it reaches the medial aspect of the clavicle. Here we have another congenital variant. This is a bifid rib here, as you can see. The problem of this rib is in its diagnosis. Usually the patient comes and says, I have something, a mass here. And unless a 3D image is done, you will always miss this case. It will not be diagnosed by reconstruction or axial images. It can only be seen in this 3D study. This is a bifid rib. Now here, look at the left side. We have an abnormal configuration of the scapula and a high position of the scapula. This is a Sprengel shoot. It's a congenital lesion. On the right side here, we have a defect. We have some part missing of the clavicle. The middle part of the clavicle is missing. This is cleidocranial dysostosis. In cleidocranial dysostosis, both clavicles may be totally missing. The lateral aspect of a clavicle, bilateral or unilateral, may be missing. The middle part of the clavicle, uni or bilateral, may be missing. In addition, there are changes elsewhere in the body. This is cleidocranial dysostosis. It's a dysostosis. Here we have pectus excavatum. The lower part of the sternum is rather depressed backwards, as you can see here. It's not straight, and this may cause a patient to have dyspnea sometimes. Even sometimes it might lead to some murmurs. Here we have the opposite. We have pectus carinatum, bulging forward of the upper part or the anterior part of anteriorly of the sternum, as you can see here. This is pectus carinatum. What do we have here? We have a very strange appearance. We have streaks of bone, abnormal bone, joining every part of the chest together. This is what we call myositis ossificans progressiva, and it's again associated with other anomalies elsewhere, especially in the toes. Regarding the fracture, there are 2 points that we need to know by heart and differentiate. The stress fracture. Stress fracture are fractures due to severe stress on normal bone. For example, people with chronic severe cough We'll have stress fractures of the rib. I will call it actually a fracture between brackets. It's very smooth cleavage with sclerosis on its end. This is another case, as again, a smooth cleavage and sclerosis of the ends. A fracture, I call it fracture between brackets. This is a stress fracture. If you find it, you have to mention it. Okay, because this patient has pain in his chest. Now here we have traumatic fracture, as you can see. There is more than one fracture, and this is a non-united fracture actually, then there is scarring in the underlying lung. Now miscellaneous lesions. If we look here, we can very clearly see that on the right side, we have the pectoralis major and pectoralis minor, where there is no pectoralis major and minor on the left side. Before jumping and diagnosing Poland syndrome, look backwards. You will also see atrophy of the muscles of the back. This was a patient with hemiplegia and actually muscular atrophy. However, in this case, this is the case of Poland. You can see the pectoralis major and minor on the right, while on the left there is very hypoplastic. And in addition, there is a defect of the chest wall, posterolateral on the left side. Okay, and this defect, this is a bony and soft tissue defect actually, but the skin is intact. And it takes place about from the 6th to 8th ribs. It's not usually present associated with the Poland, but sometimes it's present. There is always also some ipsilateral hand changes that may be present. This is the Poland syndrome. Now here we have the surgical emphysema and the mediastinal emphysema also. This is the opposite. Now we have fogging of the chest wall. We have dense breasts. Okay, we have bilateral effusion and cardiomegaly. This is a case of anasarca with chest wall edema. This is chest wall edema. Okay. Now, another case of chest wall edema, as you can see here, there is again anasarca, there is ascites, effusion bilateral, pericardial effusion, and chest wall edema. When we look here, we will see that the right breast is very dense. We were suspicious of this right breast, so we made a mammogram, and it was only the pattern of edema here. Another case of edema, but there is more lesion. The lesion is more apparent on the right side because this patient is all the time lying. Before she did a CT, she was all the time lying on her right side. So as you can see, this is right side, this chest wall edema more on the right. What we see here is abnormal configuration of the chest. Okay, this is 18 years old with a pigeon-shaped chest. And these are those beads anteriorly are rosary beads. It's a case of healed rickets. We have here a bilateral axillary lymph nodes. As you can see, this is a CT study with contrast, but the lymph nodes are not enhancing and they have the same density as, or even hypodense actually, they're like the muscles. In this case, however, again, CT with contrast, we see that the axillary lymph nodes bilaterally show enhancement compared to the muscles, and we see tiny vessels in the vicinity of the lymph nodes bilateral. This is pathognomonic of a Castleman disease. Now this case is clear to everybody. I think this is, this is right mastectomy. Okay. In this case, we have evidence of sternotomy and stippling behind the sternotomy. This is classic for cabbage. Now, inflammatory lesions. This was a case of sternotomy and cabbage, and it got infected. As you can see, there is fragmentation and sclerosis of the sternum. There is air, there is loculations of fluid, there is heterogeneity. And there is the extending from the soft tissue anteriorly and the anterior mediastinum. So this is, again, this is chronic osteomyelitis of sternum post-cabbage. Why chronic osteomyelitis? Because of the fragmentation and sclerosis. In acute osteomyelitis, we do not have sclerosis, okay? We have only a rarefaction of bone. But this fragmentation, sclerosis, is chronic osteomyelitis. This was a diabetic patient with oozing of pus anterior chest wall. CT revealed, as you can see here, there is infection of the clavicle, left clavicle, of the adjacent sternum. There is collection, there is fragmentation, there is sclerosis. In addition, We found also that there is affection of the spine, and there is an abscess, and there is affection of the lung. So this is chest wall extensive infection in a diabetic patient. This female patient had right mastectomy, and you can see here, look at the right axilla. There is a fluid level in the right axilla. There was a post-mastectomy abscess formation in the right axilla. This case, as you can see, there is pleural loculation, thick wall enhancement. This is an empyema, and this empyema extended to the chest wall. So this is empyema necessitans. This was a young female patient presenting with a right breast lump. Ultrasonography revealed fluid and abscess, and it suggested extension into the chest. Chest CT revealed, as you can see, extension into the pleura with thickening and enhancement, and extension in the chest wall, suggested tuberculosis. And actually, it was a proved case of tuberculosis. This is another case of tuberculosis in a female patient. As you can see, there are tuberculous abscesses, extensive, related to the sternum and related in the paraspinal and chest wall lesion. There is extensive chest wall abscesses, affection by this tuberculosis. This also definitely suggests that this patient immunity is markedly impaired. Now, some tumors and tumor-like pseudotumors of the chest wall. The classic elastofibroma, which lies deep between the serratus anterior and latissimus dorsi. This is the position of the elastofibroma. It's a pseudotumor. This is the pseudofibroma in MRI. Now, in MRI, the pseudofibroma may be iso-intense to muscles, may be hyper-intense to muscle, according to the ratio of elasto and fibroma within. But here, as you can see, there is bilateral elastofibroma that is very clearly seen. Now, on the right side here, we have a lipoma, okay, a deep lipoma to the muscles. And this is another case. As you can see here, we have extensive fat on the left chest wall, but look upwards in the same image, you can see subcutaneous fat separated by the fascia from the deep lesion. So they are not communicating. This is deep fat, not subcutaneous. So it is not a lipomatosis. If we find communication with subcutaneous fat, we call it lipomatosis. If you can still see separation between subcutaneous fat and this very extensive lesion, fatty lesion, it is not a lipomatosis. What we call it is, this is a deep infiltrating lipoma of the chest with an extrapleural component, as you can see here. There is extrapleural extension. This is in the MRI. Now, look here, this is a chest scanogram. Look at the left side, you can see the apex of the lung clearly. If you look at the right, you cannot discriminate the apex because there is an apical capping here. Is this an effusion? No, it is not an effusion, because apical capping of effusion is associated with veiling of the lung. We don't have veiling. The lung is clear, but we have a cap. So there is pleural lesion here, apical thickening here. Now, if you look at the axial CT image that is seen, there is what looks like irregular pleural thickening, which is very understating the lesion. While in the same patient, MRI showed the lesion extensive in the thoracic inlet, invading the adjacent chest spine and extending in the apical aspect of the lung. Again, we stress the point, in cases of thoracic inlet lesion, in cases of chest wall lesions, we must do MRI. In posterior mediastinal lesion, as we said before, again, we must do MRI. This is a chest X-ray PA view. They can see clearly the left apex. You don't see, there is capping on the right, okay? The CT image show infiltration. This is a pancreas, infiltration of the chest wall, as you can see here, marked infiltration. So in those two cases, this is a case of pancreas tumor. Now, this is a mesothelioma. Again, we have seen a pancreas infiltrating the chest wall. This is a mesothelioma infiltrating the chest wall, extensively infiltrating actually. This is another case of mesothelioma infiltrating the chest wall at multiple sites, as you can see here. So a tumor of the chest wall may be coming from the adjacent hemithorax. In this case, there is a lymphoma, there is a lymphoma of the mediastinum with bilateral extension in the chest wall, as you can see here. So the mass here is extending from inside. In this case, we have, as a scanogram, as you can see, there is a lesion abutting the ribs, extending into the chest wall and extending to the adjacent lung. As you can see, there is a soft tissue lesion destroying the ribs and extending on both sides. The epicenter of the lesion is the ribs, so it's most likely arising from the ribs. However, it extends internally and externally, and it was a chest wall undifferentiated sarcoma. This is a chondrosarcoma. I'm sorry for the image. I took it with my mobile. This is a chondrosarcoma, okay, of the chest wall. It's not a common entity. As you can see, the popcorn calcification in the lesion related to the rib and costochondral junction. On the right side, you can see breast carcinoma, and on the left image, you will see expansile lesion of metastatic lesion in the ribs. Again, this is a case of cancer breast with multiple deposits involving the vertebra and the ribs. Here, this is a case of cancer thyroid, as you can see in the up and on the right here, tracheostomy. And this cancer thyroid has metastasizes to the chest wall, causing thickening of the skin and nodularities in the subcutaneous fat and affection even of the axilla. You can see expansile lesions of the sternum and punctation and of the vertebra behind, punched out lesions. And this is a case of multiple myelomatosis. Thank you very much. We have finished with the lecture.
شكرا جزيلا دكتورة يسرية، يعني مجهود حضرتك يعني على مدار ساعتين، يعني محاضرة قيمة جدا جدا. احنا كده طبعا نعتبر لمينا الحاجات البلمونري والاكسترا بالمونري، مش كده؟
تمام يا فندم. كده احنا في المحاضرة اللي هي من سنتين، والمحاضرة دي رغم الانتربشنز الكتيرة اللي حصلت، بس يعني أرجو الناس بس ما تكونش فقدت التركيز في النص. تمام يا فندم.
لا إن شاء الله. كتر ألف خيرك، و يعني نتمنى إن شاء الله نأرنج للجزء بتاع الكيسز عشان بس نستفيد من المحاضرتين دول إن شاء الله.
إن شاء الله إن شاء الله يا فندم. بس بقى يعني
إن شاء الله.
نوصي بقى علينا عشان اللي داخل واللي خارج والحاجات الكتيرة اللي بتحصل دي عشان التركيز.
حاضر. معلش يا دكتورة يسرية، عشان دي أول سيشن للشركة معانا النهاردة، فهم الحقيقة كانوا عايزين يأجلوا النوم الأسبوع اللي جاي، وبعدين أنا قلت لهم يعني المرة دي تحديدا حضرتك هتبقي موجودة معانا، فقلت لهم يعني إن دي أفضل دعاية ليهم إن يبقى البداية بتاعتهم مع حضرتك. يعني هم الحقيقة ما كانوش جاهزين وطلبوا مني أكتر من مرة، لأن إحنا لسه عاملين الكونتراكت معاهم ده لسه أول امبارح، فهم طبعا ما عندهمش استعداد وعمالين يتحايلوا عليا. أنا اللي الحقيقة أنا اللي ضغطت عليهم، لأن إحنا بس كان يعني كنا إحنا اللي بننظم السيشنز مع نفسنا كده بس يا دكتورة يسرية. يعني كان فيه يعني أحد النواب معانا كان هو بس اللي بينظم السيشنز كده وخلاص. فأنا حبيت الموضوع يعني يبقى فيه احترافية شوية، وإحنا إن إحنا يعني نقدر نوصل لأكبر قدر من الناس وكده. فعشان كده عملنا التعاقد مع ميديكا سبيس، وزي ما بقول لحضرتك كده لسه الكلام ده يعني يومين تحديدا، ولكن يعني فحضرتك اعذرينا بس لأي انتربشن حصل أو أي حاجة حصلت في المحاضرة، ويعني إن شاء الله المرات اللي جاية هم طبعا يحلوا المشاكل دي، والحاجات دي طبعا ما تتكررش إن شاء الله تاني يعني.
ان شاء الله يا فندم. هم
برضه
يعني
احنا كمان
متعاونين جدا ويعني ان شاء الله خير باذن الله.
لا انا عارف طبعا انهم كويسين جدا، يعني انا عارف انهم ناس محترمين جدا، ونور تحديدا يعني من الناس الاكتف جدا
صراحه
والناس المحترمين جدا. فاحنا بنشكرها برضو ان هي على مجهودها قبل السيشن وخلال السيشن، بنشكرها جدا. وان شاء الله يعني تتحسن الامور، والامور تبقى افضل بعدين ان شاء الله.
ان شاء
انا
الله.
بشكر حضرتك تاني مرة تانية، واحنا منتظرين حضرتك. يعني اول ما حضرتك تبقي ريدي حضرتك بلغيني، لان هم طبعا يعني هنستفيد اكتر لما يبقى فيه الحالات بقى اللي حضرتك هتعرضيها وكده،
ان شاء
ونعمل
الله.
ديسكشن مع الاطباء.
طيب ان شاء الله باذن الله.
شكرا جزيلا دكتورة يسرية.
شكرا
شكرا يا
لحضرتك
دكتور.
وشكرا للشركه، وشكرا يا نور، وميرسي جدا،
العفو يا دكتور.
واشوفكم على خير ان شاء الله. ميرسي.
شكرا جزيلا، شكرا
ميرسي
جزيلا
يا فندم.
دكتورة يسرية.
ميرسي
الله
يا فندم.
يخليك. السلام
الف
عليكم.
سلامه. مع
عليكم
السلامه.
السلام.
مع السلامه.
الله يخليك. عليكم السلام.